in terms of follow-up, I mean, these are patients who have proven to have failed prior intervention, so I'm much more apt to follow them very closely. So in my own practice, these type patients, I'll see every 3 months with imaging, usually duplex ultrasound imaging, and follow them closely until I know we're really out of the woods.
Any patient who has an intervention, whether it's a surgical bypass or an endovascular intervention, we really feel that it's critically important that those patients undergo routine duplex surveillance, because it's much easier to deal with a focal edge stenosis before the device occludes. And so in our practice, if someone has a PSVR of greater than 2.5, we start thinking about intervening, and if that ratio is greater than 3, even if they're asymptomatic, we'll bring those patients back and preemptively treat them to avoid a stent graft thrombosis. And I think you can dramatically improve the longevity of the stent graft patency if you follow that regimen. One of the other questions that people ask is, well, how long do you need to treat with dual antiplatelet therapy? In our practice, we do it for a minimum of 1 year, but if the patient does not have high bleeding risk, we actually like to continue dual antiplatelet therapy chronically. Now, if a patient has had a stent graft thrombosis, or if they have evidence of panvascular disease, for example, they have coronary disease, or they have cerebrovascular disease, and if they're not a high bleeding risk, we and others have increasingly gone to low-dose rivaroxaban as an adjunct, largely as a result of the Voyager PAD and COMPASS trial data. And so we will, for example, treat patients with Plavix and low-dose rivaroxaban, eliminate the aspirin to help reduce the risk of bleeding complications. And for many of our patients, we feel that that's an excellent long-term anticoagulation regimen.